In this video, we're going to be going over all the antihypertensive medications. This is not questions, this is content. I like to call it the ABCDs of cardiac meds because every category either begins with an A, B, C, or D. So we'll be doing the diuretics, which are the loops, the thiazides, the aldosterone antagonists, also known as the potassium sparing. The ACE inhibitors, we call ACEs. The angiotensin receptor blockers, we call ARBs. The alpha-1 adrenergic blockers, the alpha-2 adrenergic agonists, beta-adrenergic blockers, we also call beta blockers, calcium channel blockers, and the direct vasodilators, which are the smooth muscle dilators and the nitrates. This is a pretty in-depth review of these meds. However, if you want more information, you can find that in your nursing resources under cardiac, vascular, and your pharmacology content. So let's get started. This is how the medications will be explained. You'll see the medication category on the top. Then we're going to have a quick explanation about the action and how the category works. If you're not in pharmacology, you don't want to spend too much time exhausting yourself on how that works. You already did that in pharmacology, but you do need to review that so you can understand the rest of the medication better. Then we'll talk about the examples, so that'll be your names of the medications. Remember, we're focusing on generic, which is the lowercase medication name, not the capital letter, which is the trade name. Then dangers, that is the side effects that patients should be aware of, and nurses. And then the duties, that's what our nursing duties are, what our nursing considerations are. They could be assessments, they could be monitoring, they could be teaching. If you are in nursing school, make sure you definitely pay attention to the dangers and duties section. Make sure you know those well. That's where a lot of your medication questions come from. So dangers and duties is just a little short memory tool that I use to make sure I have found that information about any medication that I am expected to learn. And if you see this ends up being kind of a nice flashcard for yourself, always do your flashcards by category, not the individual medication names, because there's too much overlap sometimes, and you only need the category flashcard. So let's get started. First drug category is diuretics. A lot of people call them water pills, and specifically we're going to be talking about the thiazide diuretics. And the action here, this is a more gentle diuretic. It's usually used first line. It causes the kidneys to excrete more sodium, potassium, and water. So remember, if we get that fluid off of somebody with hypertension, blood pressure goes down. The examples are chlorothiazide, which can also be given IV, hydrochlorothiazide, sometimes we call that HCTZ, if you've seen that shorthand, metolazone, and chlorthalidone. The dangers with this drug is maybe the medication works too well and takes a lot of volume off, causing hypotension, maybe dehydration that could lead to some dizziness. If it removes too much of the electrolytes, decreased sodium and chloride, it can cause a hyperglycemia and a hyperuricemia. Uricemia would be high levels of uric acid in the bloodstream. That loss of potassium, this is a potassium wasting diuretic. You have to be very careful. Make sure that you remember your signs and symptoms of hypokalemia, because your patient is not going to come in and say, I feel hypokalemic. They're going to start describing the symptoms, and you have to remember from your fluid and electrolyte lecture what those symptoms may relate to. So they are weakness, irregular pulse, anorexia, muscle weakness, numbness and tingling, which is paresthesias, confusion, drowsiness, fatigue, bradycardia, weak irregular pulse, U-wave on EKG if you happen to do that with your patient, nausea, vomiting, and decreased bowel sounds. So what are my duties as a nurse? It's to monitor the blood pressure, of course, watch that fluid volume, and we monitor that by doing daily weights. We're going to go ahead and do an I&O balance because we do want to see if the diuretic's working, and watch those electrolytes. Definitely watch for the signs and symptoms of hypokalemia. We do want them to increase potassium foods, and they can take potassium supplements. Even though sodium is down, we don't want them to eat sodium because they do have hypertension. So we're still limiting salt even though sodium levels may decrease. We can adjust these. Remember, nurses aren't allowed to change the frequency, but we are allowed to adjust the time. So if the diuretic is making them get up in the middle of the night to go to the bathroom and they have nocturia, which is annoying, then we can change that. So maybe we can give it to them at 8 in the morning and 8 at night, or 6 in the morning and 6 at night instead of 10 and 10, so that they're not peeing all night. We do want them to know they will be getting up to go to the bathroom frequently. Make sure they're not a fall risk when they do that. Make sure they have well-lit hallways and everything so you can get to their bathroom. And with that uric acid, we want to monitor for gout flares and uric acid levels, especially if they have a history of gout. Take a screenshot if you need to. That is your thiazides. The next category of diuretic, another water pill, is the loop diuretics. And these are stronger than the thiazides, so if people need more diuresing effect, then we'll go with this one. Again, it works in the nephrons. It blocks that reabsorption of sodium and chloride, which therefore blocks the reabsorption of the water, and therefore the water gets excreted. Thus, volume leaves the body, and anytime volume goes down, blood pressure goes down, which is what we want if somebody's hypertensive. The examples are furosemide, bumetanide. Both of these can be given PO, IM, and IV. Dangers, they work in the nephrons, and it's the same as the thiazides. So if you remember the thiazides, you've got the loops. Duties, again, same as the thiazides. The only thing I would add here is that if you're going to give this drug IV push, make sure you do it slowly over 1 to 2 minutes. If the patient complains of tinnitus, which is that ringing in the ears, make sure that you slow down the IV push. Final category of the diuretics is the aldosterone antagonists. So these are different. These are potassium sparing. The other ones wasted potassium and caused hypokalemia. These spare potassium, meaning they hold on to potassium, and so their danger is going to be hyperkalemia. So if we look at how they work by blocking aldosterone, and aldosterone makes the patient hold on to sodium. So it's going to be blocking that, which means the patient will let go of sodium, and we know water follows salt right out, and therefore water will leave as well, causing the blood pressure to go down. This drug is also used in the treatment of heart failure. When I learn things, I like to learn them once, so I will include other uses for these drugs here. Examples, spironolactone. A little hint here on the slide is something I do. If you mispronounce that on purpose and say spironolactone, that will always remind you that it spares potassium. And it's really the only one we talk about. So if you got spironolactone, then you will always remember that. The dangers are the same as the loops and the thiazides, no difference except for the hyperkalemia. So that's really the only thing we're going to talk about here. What are high potassium signs and symptoms? Drowsiness, muscle weakness, twitching, paresthesia of the hands and feet, even around the mouth, diarrhea with hyperactive bowel sounds, dysrhythmias, irregular pulse, peak T on ECG, ventricular fibrillation, and cardiac arrest. So you can see that hypo and hyperkalemia have some similarities, drowsy, muscle weakness, but as far as the EKG is a little bit different. But I would say if you are dealing with hyper or hypokalemia, get them both on that cardiac monitor. That's if they're symptomatic. The duties here, same as the loops and thiazides, except in this case we'll be doing the hyperkalemia teaching instead of hypo. So hyperkalemia teaching is that they should avoid potassium foods, and also they have to avoid salt substitutes. That might sound weird to you, but the reason is because salt substitutes like Mrs. Dash, those are potassium salts. So if the client is already at risk for high potassium, don't give them salt substitutes. The medication is also contraindicated in patients with renal failure, and that is because renal failure increases potassium all on its own. So if you combine spironolactone and renal failure, those potassium levels can go up high and then possibly lead to those EKG dysrhythmic changes that we're so worried about. So this is not a med slide, but because we just talked so much about potassium, and in the loops and the thiazides, we want them to eat potassium foods, and in the spironolactone, we don't want them to eat potassium foods, so I think it's probably a good idea to remember what those are. So I just threw this slide in here. And bananas, potatoes, don't forget, potassium potatoes, stay away from that potatoes. And then your dried fruits, and then you've got some other stuff here, winter squash, spinach, broccoli, beets, greens, avocado, cantaloupe, beans and lentils, oranges, orange juice, and tomatoes. So those are some of the big ones. Okay, the next kind of medications here are going to be working in the Renin-Angiotensin-Aldosterone system. There's two meds that work in this system to help decrease the blood pressure. And just take notice, the patient doesn't have to have a problem in this system for the doctor to use this medication to fight high blood pressure. It's just one way that we can do that. So the drug category here is the ACE inhibitors. And so how does the ACE and the RAAS connect? If the medication blocks the ACE enzyme is responsible for making angiotensin 1 go to angiotensin 2. So that's not going to happen now. And if that doesn't happen, if the angiotensin piece of this doesn't happen, then the rest of the RAAS pathway is stopped as well. So why does that help hypertension? So let's keep looking here. If we stop angiotensin, here's another trick. Angiotensin to me sounds like tension. So think of stopping tension in the vascular system. Well, then that would stop vasoconstriction. And then we already talked about how aldosterone causes sodium retainment and water retainment. So if we stop aldosterone, that stops sodium retention and therefore water retention as well. And so if you really look at this drug, this goes after high blood pressure two ways. It stops vasoconstriction and it stops the sodium water retention. And by stopping both of those, blood pressure has no choice but to go down. This is a great drug. It is also used as a first line with those diuretics, because the diuretics could be first line. These are first line choice for the doctor as well. The examples here are captopril, enalapril, lisinopril. If you notice, they all end in pril. What's the dangers? Well, if we drop that blood pressure, the client could definitely get hypotensive and maybe a little problem like if they get up too fast, that postural hypotension. If we stop sodium from being retained, we stop that aldosterone from holding on to sodium, well, what's the opposite electrolyte of sodium? Potassium, and therefore we've got hyperkalemia as a side effect here again. Insomnia, loss of taste. Watch this angioedema one. Angioedema is basically like hives under the skin. That's what's different. So hives, you know, we see on top of the skin. Think of that going on under the skin, and maybe they'll complain of some throat swelling. That's not good. And just a little FYI, the ACE enzyme has some other roles in the body, like getting rid of this stuff called bradykinin. And when that is inhibited and the bradykinin builds up in the body, it can cause some other side effects like that dry, non-productive cough. Not that the cough is a problem, but they might start wondering why they're coughing all the time. So as a nurse, my duties here definitely to monitor the blood pressure before and after giving, always before and after giving these medications. Watch those potassium levels. Watch for the hyperkalemia signs and symptoms again. Get the patient up slowly. The first dose of this can actually cause a fainting, which is a syncopal episode, so be careful. And it's interesting, we might not have to worry about supplementing potassium if giving a loop or a thiazide, because if they're on this drug too, the loop and the thiazide depletes potassium, but this one brings it back. So that might equal it out. But so I guess the overall concept is just monitor potassium with any of these drugs. If this dose is skipped or they suddenly stop this, and I can say that for any of the blood pressure meds that we're going to talk about, they should never skip or stop a medication. You have to make sure they get those refills, because if they do, it can result in a quick rebound hypertension, and they could actually go into a hypertensive crisis and stroke. So always advise your patients on hypertensive medications not to skip a dose, not to stop, and to really plan ahead to get their refills. Another category of drug that works in the Renin-Angiotensin-Aldosterone system, or RAAS, is the angiotensin receptor blocker. So hopefully, because we talked about angiotensin a second ago, that word is now making sense. We know that causes tension. So if we block that, all of RAAS gets blocked again. So we don't have to talk about this again, because if it's working in RAAS, it's doing the same thing the ACE inhibitor did. So this drug can be used as first line also. The examples are losartan, candesartan. They end in artan. Dangers, because they work in RAAS, we can just say it's the same as the ACE inhibitor, except for the other signs and symptoms that have to do with the bradykinin. This one won't cause a cough. And so the duties, again, are the same as the ACE inhibitors. And honestly, ARBs really are only used if that client gets that annoying cough on the ACE inhibitor. The doctor will switch to the ARB. That was kind of their original purpose. And in the meantime, I do believe that people can be on ACEs and ARBs at the same time now. But anytime you have a drug where you think they're being used in the same category, always a good idea to maybe call your pharmacist, because they're usually up on the latest research. They'll tell you if they can be dosed together or not. So far we've done the 3 diuretics, and now we just did the 2 RAAS blockers, ACEs and ARBs. And so a little hint for you here, if you can remember that there's 2 A's in RAAS, or AAS, that can remind you that ACEs and ARBs work in RAAS. 2 A's, 1 A for ACE, and 1 A for ARB. So that's what I use as my memory tool to remember where they work. Okay, there's another system that we can go after, or the provider can order, that impacts the blood pressure, and that is your fight and flight system, your sympathetic nervous system. Anytime fight and flight is happening, blood pressure goes up. So this is a great pathway to maybe block to lower blood pressure. Again, it doesn't have to be the main source of why the patient's blood pressure is up. It's just another way that we can impact hypertension. So in this case, we're going to talk about the beta adrenergic blockers, also called the adrenergic antagonist, beta blockers. And how do they work? We have medications that go in and they block fight and flight at the beta receptor. The beta receptor is part of the fight and flight pathway. And so if we block fight and flight, blood pressure has no choice but to relax and go down. And there are beta blockers that are beta 1, which is the receptors in the heart. Those are called cardioselective. And they can use those not just for blood pressure, they can also use them to treat tachycardia, which beta blockers do treat tachycardia. When you guys do dysrhythmias, you will hear that. They can also help in heart failure as well, though I've been seeing some evidence that if people are on beta blockers for a long time, it can start causing heart failure. So that's a little bit tricky there. And then we also have these beta blockers called non-cardioselective. So they don't just go after the beta receptors in the heart. They kind of go after all the beta receptors in your body. So they can kind of calm down the whole body. They won't just go after the heart and the vascular system. And we see those being used in people with hyperthyroid, people that their system is just revving from all that, thyroid hormone. And we will see beta blockers there too. So this is a drug you'll see throughout nursing school. The cardioselective ones are atenolol, metoprolol, cartilol. Some of these are also available in sustained release. Metoprolol, atenolol, propranolol are also available IV, and propranolol is the one that the hyperthyroid patients use. It's non-cardioselective. It just relaxes them, it calms them down. And I didn't put it on this slide, but if any of you guys have testing anxiety, propranolol is a wonder drug for testing anxiety. You physically can't have anxiety when you go take your test if you take a little dose of propranolol. So the dangers here are if we block fight and flight, what could that cause in the other effect? It could cause everything to be too relaxed. So hypotension, postural hypotension, bradycardia, even it could kind of calm down the respiratory response. We're going to talk about in a sec, because there might be some people you don't want to decrease that respiratory response in. It can cause depression. Imagine kind of drinking that cup of coffee in the morning with caffeine and just not ever really feeling it. That's kind of like being on a beta blocker. So it can lead to depression, tiredness, fatigue, and males can have sexual issues. So you definitely want to make sure you educate and teach them that there's other things that can happen in the body besides just the response in the heart. And so that's our duties: to monitor the blood pressure, again, before and after, heart rate this time too, mood, sexual side effects. Get them up slowly, dangle them at the bedside first, make sure they're not dizzy. So with the respiratory issues, don't give to asthmatics, even COPDers, be very careful. This is another interesting one. When a diabetic goes hypo, so low blood sugar, they know they're going low because they start to feel confused, they start to feel shaky and sweaty. Well, that blocker won't allow them to feel shaky and sweaty. So a diabetic won't know when they're hypoglycemic, and that can be really dangerous because hypoglycemia can go into a coma. So with your diabetics, it's not contraindicated at this point, but we have to use caution. We have to teach them and make sure that they're testing their blood sugar more often because they won't feel when they go hypoglycemic. A second category of drug that is in the fight and flight sympathetic nervous system is the alpha adrenergic blockers, alpha 1s. These receptors, just like the betas, are in the fight and flight pathway, so we can go after them to relax the body and lower the blood pressure too, just like we did with the betas. You will also hear these drugs being used to improve urine flow in men with prostate hypertrophy. So if you've gone to the prostate class, you would have already heard these drugs. Remember, medications can have different actions or different uses. Examples: doxazosin, prazosin, terazosin, all end in zosin. We don't really have to talk about this. It's the same side effects as the betas because we're blocking the fight and flight response. Hypotension, feeling faint, dizzy. They can get a rebound headache. Tell the doctor if they have that. Pounding heartbeat and weakness. So what are my duties? Same as the betas. Monitor the blood pressure, heart rate, get them up slowly. You'll notice here we're not talking about the diabetics or the asthmatics. These drugs are a little bit more gentle than the betas, and there's no contraindications for those asthmatics and diabetics like there was for the betas. A third category that works again in the sympathetic nervous system, fight and flight. These are more alpha receptors, except these are alpha 2s, and be careful, these aren't blockers. These are actually stimulators. They're agonists. So I call these like the funky receptors because by stimulating this receptor, it actually blocks the fight and flight pathway. So that's a little bit different. So I put that there in the action. By stimulating this pathway, oh, and these receptors are also located in the brain, so they're like a CNS drug. By stimulating these, it causes the body to relax and blood pressure to drop. These drugs you'll also see being used in people withdrawing from narcotics, heroin, opioids, because when that happens, blood pressure tends to go up, and the brain, they have a little, some hallucinations and things like that sometimes coming off of these drugs, and it just relaxes them, relaxes their brain, relaxes their blood pressure. Examples: clonidine and methyl-dopa. Do not get that confused with your Parkinson's levodopa drug. Not the same thing. Dangers: same side effects as the alphas and betas. The only difference here is added CNS effects. These are brain drugs, so watch sedation. Maybe not a good idea to take this drug and go driving. Especially do not, or very, very careful with these older adults. Depression, confusion, and a little interesting, possibly side effects of hemolytic anemia and hepatotoxicity. Duties: same as the betas and the alphas. So this is just a quick summary slide now of the sympathetic pathway medications. It's the betas and the alphas. So just FYI, as you're going through nursing school, any medication categories with the words adrenergic, beta, or alpha are always working in the fight and flight pathway. So the hint in the middle says here, pay attention to the category if it's an agonist or an antagonist. So if it stimulates the pathway, we know all of that stuff, hypertension, heart rate, all this stuff's going to go up. If it's a blocker of the fight and flight pathway, all those things are going to go down, right? So we've been actually talking about inhibiting here. And so, yeah, so for hypertension, the pathway is inhibited by beta blockers, alpha 1 blockers, and alpha 2 agonists. I call it, it's the opposite receptor. I called it the funky one. And all those relax the blood pressure. The only medication that begins with the letter C, calcium channel blockers. This is another place that we can try to lower blood pressure by going right after that calcium channel. If we block the calcium channel receptors in the cells of the heart, it causes decreased cardiac contractility, so it's relaxing, causes a decreased rate of the sinus and AV node conduction, again relaxing. We use this drug to treat a lot of things, not just hypertension. It can treat angina. It can treat this special type of prismatals, angina. It can treat atrial fibrillation, and this actually is a first-line drug for the African Americans. So if you've heard so far, we've talked about all our first-line drugs. The diuretics are first line, the RAAS drugs, ACEs and ARBs, are first line, and these are first line, the calcium channel blockers. Examples: nifedipine, amlodipine, diltiazem. Diltiazem is available IV Verapamil, available IV, and clevidipine is IV and used for severe hypertension. Dangers: if we relax that vascular system by blocking that calcium channel receptor, we're going to, of course, cause hypotension. We can also cause bradycardia, vasodilation, edema. You relax the heart too much, it could fail, could exacerbate heart failure. It also relaxes the GI system, which then causes constipation and nausea. Some other side effects they could complain about are headache, fatigue, dizziness, flushing, and palpitations. Constipation is a big reported side effect of these drugs. So what are we going to do? We're going to monitor that blood pressure before and after, watch the heart rate because this one does affect heart rate too, and watch that GI system, make sure that they are going to the bathroom okay and not having any issues there. So just want to recap real quick. The only two so far that have caused bradycardia are the beta blockers and the calcium channel blockers. They're the only ones that mess with the heart rate. Final category, it's the direct vasodilators. First example is called hydralazine. These act by going and impacting the vascular smooth muscle right there to cause vasodilation. So because these aren't working in like a system like fight and flight or the Renin-Angiotensin-Aldosterone system, there's really no other side effects except just messing with the vessels. So hydralazine can be given PO, IM, or IV. So the dangers, like I said, just messing with the vessels, hypotension. If you drop the blood pressure, there's going to be a reflex tachycardia, possibly a headache, some sodium retention, drug-induced lupus syndrome, and possibly some peripheral neuritis with long-term therapy. The duties here, again, are to get them up slowly. I think that's been a theme throughout, get them up slowly. Watch for tachycardia here, and if they do have to be on this medication a long time, B vitamins always protect your nerves. So if you ever have something where you have a risk of peripheral neuritis or paresthesias, vitamin B6 should be mentioned. Another direct vasodilator is nitroprusside. Again, works right on that smooth muscle to cause vasodilation. This one is more so given in a hypertensive crisis. It has a very, very rapid response. Because it works so rapidly and drops that pressure so quick, that reflex tachycardia is intense, and you have to be careful dropping down somebody's blood pressure too fast because the body doesn't necessarily like fast adjustments, and therefore this drug should be given preferably in the critical care setting with continuous ECG and blood pressure monitoring. As far as the drug itself, once you prepare it, make sure you use it immediately within 24 hours and protect it from light. This is the final med slide. The final vasodilator is the nitrates. So these work by dilating coronary arteries. So one, they could improve blood supply to the actual heart muscle. They reduce cardiac workload because they decrease venous return to the heart because of peripheral vasodilation, which therefore decreases preload. We use these drugs not just for hypertension, we also use them for chest pain, angina, and to reduce preload, to reduce the work on the heart. Examples: nitroglycerin. Nitroglycerin is a big one. If you did a chest pain lecture, you know you talked about nitroglycerin. It is available sublingual, extended release, as a patch, topical, as a paste, which we do an ointment by the inch, IV, translingual spray. And then the only other one is the isosorbide, which is the extended release nitroglycerin, basically, and that's the PO form. The dangers here is that quick drop in blood pressure. Make sure that you get them up slowly. They could have, again, a rebounding reflex tachycardia. They could feel dizzy, faint, syncope, have some blurred vision, dry mouth as they dilate there. And watch the headaches. If they're kind of new to the drug, they might experience a headache, but that can typically go away if they get used to it. So our duties as a nurse: monitor the blood pressure and heart rate. Don't take this medication with any erectile dysfunction medications like Cialis or Viagra, because that also causes hypotension. So then you're doubling up on that effect, and there can be syncope and dizziness, and even anginal episodes, and that would be a 911 call if that happens. If you're using the patch, make sure to remove all previous patches when applying a new one. If it causes a headache, you can try to just place that patch a little bit further away from the head area. That might help. When you're giving it, make sure that you wear gloves with the topical because you don't want to get nitro on your hands and then end up with a headache yourself. If you're going to give for chest pain, you can give the sublinguals, and we give 3, so it's basically 1 every 5 minutes. If the chest pain is not better after the first dose, you're going to call 911. And if we're giving IV, we're always supposed to use a special tubing. It's actually like a blue colored tubing. You don't want to use regular tubing because the nitroglycerin actually will go into the tubing. And that's the other reason why it also has to be in a dark glass bottle for the sublingual pills, because the nitro just wants to seep out of the pill. So as far as the IV, back to IV, titrate that slowly. Again, we talked about we can't drop it quick, because we have to make sure the patient is actually going to tolerate that drop in blood pressure and not have a side effect from it dropping too fast. So that was a lot on nitro, but you do see nitro a lot. And like I said, if we're going to talk about nitroglycerin, I want to talk about it once and remind you of everything it can do and be used for. So that is the ABCDs of cardiac medications. You can see maybe why I call it that now. The A's are the ACEs, the ARBs, the alphas, the B's are the betas, the C's are the calcium channel blockers, and the D's are the diuretics and the direct vasodilators. So that was a lot of information on the cardiac medications. This is a good video to watch at least 2 more times to really start absorbing this. Take some screenshots so you can just kind of cut out and make your own flashcards and you can have them. But if you enjoyed going over this content, there's more videos like this. There's videos going over questions involving these medications. See how you do, see how much you can remember. But if you like this, please subscribe to our channel, like this video, and you can also find us at sciencestrategies.com.